everyone, I'm Wafa, and today we'll be covering a case on pelvic organ prolapse. I have two lovely volunteers who would be doing the case. One of them would be taking history, performing examination and explaining the diagnosis. The other one would be explaining the management plan. So I'll be having Krishna and Ziba. Let's read the scenario. 55-year-old Katie Wilson referred by her GP with symptoms of genital prolapse. The GP tells you that she's asthmatic on an inhaler. So let's listen to Krishna while she's taking history, examining and explaining the diagnosis.
Hello, I'm Dr. Krishna, one of the doctors in the Urogynecology clinic today. May I confirm your name and age, please? Hi, doctor. I am Katie Wilson. I'm 55-year-old. So, how do you like to be addressed? You can call me Katie. Well, Katie, I come to know from your GP letter that you have some problems of something coming from down below, and you are an asthmatic on your inhaler. Am I correct? Yes, doctor. What is your concerns and expectations of today's meeting? Well, doctor, I'm having this problem for the past 1 year and it is getting worse. I had similar complaints for which I've undergone surgery to remove my own. But even in spite of that, I'm getting this again. I'm so sorry, Kathy, that you're undergoing this. But don't worry, definitely we will try together to solve out this problem. Okay, doctor, thank you. Before addressing your concerns, may I ask you a couple of questions which will actually help us in our discussion today. And also, I would like to examine you in the presence of a chaperone with your consent and arrive at a suitable, most probable diagnosis. Is that okay, Kathy? Yes, doctor, sure. Okay, Kathy, can you tell?
Okay, so we'll pause here. You can see that Krishna's had a really good introduction, and she only took, I've counted here, 1 minute, so that's a great timing, well done. She introduced herself, her name, her role, confirmed the name and age of the patient, and also confirmed why the purpose of the visit. She inquired if she has any concerns, answered them, reassured the patient that there's a solution, and then she set her agenda. So this is the perfect timing. 1 minute. If you can go down to 50 seconds, then that would be really good. So let's continue with the history.
In your own words about your complaints. Doctor, I'm having this problem for the past 12 months of something coming down below, but recently it got worse. And sex is also uncomfortable, doctor. Because of this, me and my husband having some problems. Oh, I'm so sorry, Kathy, that it is really affecting your relationship. It's okay, doctor. You have any problem with your bowel works? No, doctor. Any constipation? No, doctor. How about water works? That's fine, doctor. Are you in the habit of drinking more cola or coffee? No, doctor. Do you lift any heavy weights? No, doctor. Okay. How about you said you had some surgery for the removal. Can you tell me about this? Yes, doctor. 4 years before, I had this problem of same problem of something coming from down below. What my doctor called as uterine prolapse, and she tried using, applying pessary for me, but actually it got failed because I got ulceration and infection. Oh, I'm so sorry that you had a difficult time. It's okay, doctor. Then after that, my doctor advised me to remove my womb from down below and removed. How is the recovery? Oh, recovery is okay, but again, see, after now I have this problem. Oh, I can really see it is affecting your quality of life. But definitely, we can definitely make something good for you. Okay, it's okay, doctor. And are you on were your tubes and ovaries also removed? No, doctor. Are you on hormone replacement therapy? No, doctor. Okay, can you tell me about your have you been ever had pregnant before? Yes, doctor. I had three teenage daughters. All were delivered normally. And okay, any problem with your after your delivery? No, doctor. Okay, that's good to know. And apart from asthma, are you having any other health conditions for which you are on treatment? No, doctor. Are you allergic to any medications? No, doctor. Apart from the surgeries, this present surgery that you told me, any other surgeries in your tummy or pelvis down below? No, doctor. Okay. And are you? How about your cervical smears before your surgery? They were normal, doctor. That's good to know. And any contraceptions before? I used my partner always uses condoms, but now it's okay. Okay, I understand. Okay, and are you aware of your blood group? Does A positive? Any reservations for transfusion? No, doctor. Okay, and sorry, may I ask you some personal questions, which we generally ask to all the women who come here? Yes, doctor. Okay, do you smoke? No. Any alcohol? No. Any recreational drugs? No, doctor. Okay, what do you do for a living? I'm a homemaker. Whom do you live with? I live with my husband and my 3 daughters. Okay, do you have enough support at home? Yeah, sure, doctor. That's good to know. And is there any specific family history of concern that you'd like to tell me? Yes, doctor. My mom and my sister had the same problem around the same age. Okay, and are you aware of the height to weight ratio? I think my GP is told it's on a little higher side, but I'm not exactly sure. Okay, that's fine. So thanks for sharing all this information with me. Is there any other additional information that you'd like to tell me? No, doctor. Okay.
Okay, so let's stop here. This is the end of the history. Well done. Krishna, you did really good, and I'm going to give you a big heart because what I really liked is that you did have appropriate reactions to the patient's complaint when she told you at the beginning that she has concerns when you asked her. That's number one. Again, when she told you it's affecting her sexual life, number two. And then you did it for the third time again when she told you about her experience with the pessary. So I really like the fact that you reacted. I'm going to give you another heart. So that's 3 hearts for you. If you could see that the language she used was reasonable, friendly, patient friendly, easily understood by patients. She was systematic in her history as well. And I've written down here that she identified risk factors for the potential diagnosis, which is a prolapse, like coughing, heavy lifting, and constipation. And just one point, Krishna, why would you want to inquire about contraception before the hysterectomy? That's not going to change anything, so no need to ask about that question. Smears, it's good that you didn't ask her how about your cervical smears right now because she is hysterectomized, so it's good that you asked about her smears before she had the hysterectomy done, so well done. Plus, I wouldn't think that asking about smear history, even if she had a hysterectomy done, because it was a total abdominal hysterectomy. Sorry, it was a vaginal hysterectomy, so that means the cervix was removed. If it was an abdominal hysterectomy, then you would think maybe it's a subtotal one. If there's an abnormal cervical smears before that, then she would be having some smears now. But since it was a vaginal hysterectomy, everything was removed with the cervix. Then if she had previous abnormal smears, that wouldn't change anything. You would not be doing anything towards it, okay? I really like the fact that you were actively listening. So in some point, you were responding back to the patient, showing her that you were listening to her. If you can see here on the screen, this is the history template, the general one for prolapse, genital prolapse. What Krishna missed was aggravating and relieving factors. So does anything make it better? Anything make it worse? Why is this question important? Because she feels heaviness or a lump down in her vagina or down below. And it can either be a prolapse, it could be a vaginal cyst, a vaginal abscess, it can even be urethral diverticulum. So in order for you to think about which is which, usually a prolapse, there won't be pain, sometimes pain with sexual intercourse. But then if it's a cyst or it's urethral diverticulum, it won't be aggravated by lifting heavy objects or standing or walking, climbing stairs, and it won't be relieved when she lies down. So inquire about aggravating and relieving factors would help you going towards, yes, I think that this is a prolapse. And again, when Krishna, you went to medical history, it's good that you didn't repeat the question on asthma because the GP told you she's asthmatic, but inquire about her asthma control, because if it's not controlled, then she'll be coughing, okay, and that would put strain on her pelvic muscle, and that could be a reason why she's having a prolapse again after her previous hysterectomy. So that's an important question. Inquire about her asthma control. Let me see here what I've written. Yes, I do not have any other comments, and I've written here as well that you didn't repeat the surgery question when you came to surgical history, because she did tell you at the beginning that she had a bad experience with the pessary, she had hysterectomy to treat the prolapse, uterine prolapse. So you asked her any other surgeries apart from it when you came to the part of the surgical history, so well done. Okay, so let's come now to examination. Let's see what Krishna did.
Now, examine you with your consent in the presence of a chaperone, and I will record your weight to height ratio. I'll record all your observations like pulse, temperature, blood pressure, and respiratory rate, and oxygen saturation. But also, I would like to just examine your chest to look for any pieces, and I'd like to examine your tummy to look for any masses or palpable bladder or any tender points. And also, I'd like to just have a look down below to just see how would the skin, any atrophy, any skin changes, and also just look for the bulge and how about what is the tone of the perineal, the pelvic muscles. Okay. So from my examination, from the details, the information that you had given me, so you seem to have a condition what is called as post-hysterectomy vault prolapse, and this is the stage 2. Actually, this occurs. Oh, is it so? Yes. So actually, this occurs for 1 in 10 women who have undergone this operation. And actually, now my colleague will come and tell you about this. Okay. Okay, doctor. Thank you. Hello, I'm Anshul.
Oh, sorry. Okay, sorry for that. That was a mistake. So let's see examination. Christian, you did cover the points in examination, but it was too detailed, and that would waste time for you. You only have 10 minutes. You can't be really spending more than a minute explaining to the patient what you're going to do in examination. If it was a structured discussion, yes, you would want to show the examiner why you want to examine and mention details to justify it. But for a patient, you just say that in the presence of a chaperone, I would like to examine you. So, Krishna, you said after your consent. You don't really need to say that sentence. Okay, you can say it to the examiner though. But for a patient, when you tell her that I want to examine you, do this, this, and this, is that okay with you? That's you indirectly taking consent from her. So you don't have to mention that sentence after your consent. The examiner would understand that you did take her consent when she tells you, yes, you can do that, and then you go and examine. You mentioned the vitals, so you mentioned temperature, oxygen saturation, respiratory rate. I do think that you mentioned that because she's asthmatic. She's not coming because of her asthma. She's following with the doctor for her asthma and her GP as well. You don't have nothing to do with asthma here, okay? And also chest examination, you have nothing to do with that. That was just a total waste of time. So you just need to mention that nurse chaplain will take your BMI and check your blood pressure, your pulse, and then I'll be having a feel of your tummy, and then I would want to do a speculum examination, the same one that you used to have for your smear tests, just to see where the heaviness is coming from. That's it. No need for details. I want to look at this. I want to look at that. Just make it as simple as you can. Then what else? Yes, when you came to explaining what she has, just explain it more and do it simply. So you can just say that when I examined you, I did find where the heaviness and the lump that you're feeling is coming from. It's that the top or the upper part of your vagina has dropped down a little bit. So that's how you explain it. She will understand it because she did have a uterine prolapse before. All right. So make your explanation of the diagnosis as clear as possible to fully explain what she has. Use simple language, and at the same time, when you're explaining to the patient the examination, please make it simple and in points. Not too much information, because you do want to have around 6 or at least 5 minutes to counsel the patient about her management options. All right, so let's come to the management plan. So now let's come here. Okay, so I do have the findings here in front of me. It's in the screen in front of you as well. From the history, sexual intercourse is uncomfortable. She had a history of uterine prolapse 4 years ago, and the pessary did cause complications. That's why she had a vaginal hysterectomy. She's asthmatic, on inhaler. Mother and sister both had pelvic organ prolapse. On examination, BMI 40, stage 2 vaginal vault prolapse. So you can see here that she has multiple risk factors, and I hope that all of you could pick them up. So the management plan would be working around these risk factors and then the other management options. So the patient is going to ask a couple of questions to which Ziba is going to answer them. The first one is, why did this happen again after I had a uterine prolapse? What are my options? And if I do have surgery this time because I had it last time, would it come again, the prolapse? And when Ziba mentions the pessary, the patient says, no, I do not want a pessary. So counseling this patient would be quite easy because she did have a previous experience with pelvic organ prolapse. I'm sure she was instructed on pelvic floor exercises, reducing the weight if her weight was heavy, and also pessary. So what Ziba needs to do is just briefly explain those, touch on a pessary just to see if the patient would want it, and then explain the surgical options fully, weighing the risk and benefits of each, because this is what the patient would want right now. So let's come and see Ziba. Let me just open this.
So Katie, now I will discuss the available options with you. I will also tell you about the risk and benefit of each option and what will you expect with each, so that you can have an informed choice. Okay, so doing nothing is an option, but as it's affecting your quality of life, you need help and we need to do something about it. Some measures can help not only in reducing the chances of worsening of your symptoms, but these will also help in better outcome of surgery if you will opt for that. Okay, so these measures include reducing in weight and control of your asthma, as both of these may increase the pressure on the supporting structure and may increases the chances of coming it back after surgery. So it will reduce the chances of coming it back. And the other thing that we can do is to strengthen the muscles around here, the vagina, by doing exercises. Okay, and this will also help in reducing the symptoms to come back after surgery. Katie, I can see that you had problems with the pessary in the past, but we can still use them to buy time before surgery, so that you can reduce weight and have better control of your asthma. The problem of having ulcerations and having infections can be reduced by regular checking of the pessary, and we can use estrogen cream as well to make the lining of the vagina more supple, and have more good blood supply of the vaginal lining, and so that the chances of having ulcerations and infections will be less. Am I making sense, Katie? All right. And the last option is having surgery, in which the vagina will be stitched on the back, on your lower back, or on the side of the pelvic wall, and it can be done by your tummy or via your vagina. Okay. If you will do it by your tummy, it can be done by giving a cut on your lower tummy at the bikini line, or we can do it by keyhole surgery. But for keyhole surgery, we need expertise. Okay. So the benefit of having the surgery is that it's a definitive option, and if you will do it by tummy, the chances of coming it back is less, but as we need to use a mesh, that is a synthetic material that need to be used, the risk of this mesh can be there, because it's a foreign body, and the body need try to expel it out, and it may migrate in the bowel, or it may come out to the vagina, or it may cause long-standing back pain. Okay. Do you have any question? Okay, so the other option is to do this surgery via vagina. The benefit is that there will be no scar, and the recovery is fast, but it may cause pain during sex, and there are high chances of coming it back. And it may also cause some problem in waterworks as well. Okay, am I making sense, Kathy? Yeah. Do you have any other question? Yeah, yes, why it happened to you. Katie, there may be various reasons of coming it back after having surgery. And in some of them is that if there is any thing that causes increase in pressure inside the tummy, and the supporting structure around it, like having more weight or having long-standing cough, it may cause to coming it back again. And in your case, I can see that your mother and sister also having the same problem. That indicates that your tissues are having inherent weakness. So if even a little increase in pressure, it causing these symptoms to come back. Okay, am I making sense, Katie? Yeah. Okay. Yeah. Will it happen again? Your worries are valid, Katie, and unfortunately, yes, it may happen. As I said, that there is some inherent weakness in your tissues, but we can reduce this one by reducing the weight and better control of asthma, so that there will be no undue pressure on the supporting structures. Okay. Yeah, so I gave you a lot of information, Katie. So I will now like to give you some information leaflet so that you can go through it and make your decision. I will write back to your GP as well, and I will inform my consultant. In the next appointment, we can discuss what you will decide and we'll move further. Okay, thank you for.
Okay, so Ziva, I think I'm going to be holding this all the time while I'm talking, because I did really, I literally loved your counseling. If I was a patient, I would have felt comfortable, I would have understood everything, and I wouldn't be worried actually about why did this happen again, and if it will happen again. You gave me everything, and even you addressed all of the patient's concerns. So well done. It was really, really good. So the things that Ziba did well, she communicated effectively. She used patient-friendly language. I didn't pick a single medical jargon. She had a balanced view or comparison, the risks and benefits of each surgical option. So there were 2 surgical options, and she covered them really well. There's some few information that we're missing, but they're not that. I mean, they are important, of course, but they're not. What can I say? So what I wanted to say that what's important is the overall impression, or the way that she conveyed the information to the patient. Missing out a risk or 2, that wouldn't make a problem. Or, for example, missing a length of hospital stay or the type of anesthesia like Ziba missed. That wouldn't be a problem as long as she did everything correctly in a very nice way. The other thing is that I've written it down here, she gave information to the patient in manageable amounts. So in between, we can see she was asking, am I making sense? Do you have any questions so far? All right, so let's come here. And what I really love, Ziva, that you respected the patient's wish of not wanting a pessary. Okay, because it is an option that she can try before surgery, because it's just a stage 2. But still, you respected that in view of her previous experience. So well done. Also, I really like that you justified each option, even the lifestyle changes, the pelvic floor exercises. And I've written down some points here. I really like that you gave a mini baby agenda at the beginning when you were talking about what are the options. And you gave the option of doing nothing, But since it's causing her some symptoms in terms of painful sexual intercourse, then she would need for sure some treatment, right? Something to be done. Her BMI is high, it's 40, so you talked about weight loss. How about you link her with a dietitian? Okay, that would be really good. You talked about her asthma control, so you can tell her that having chronic cough can put strain on your pelvic muscles, and that can weaken it and make the prolapse get worse. So you did say that all of these measures would really decrease the chance of the prolapse getting worse. And what I loved is that you linked it to the chance or the risk of it recurring back again after she has surgery. So these lifestyle changes have to be maintained even when she has surgery and after surgery as well. So having surgery doesn't mean that that's the definitive solution. She still has to be working on the lifestyle changes, and you conveyed that in a really clear, concise, nice way. You mentioned supervised pelvic floor muscle exercises. And when you came to the surgery, you mentioned the benefit and risk of each. And I really love the way that you compared between both of them. But I do have some corrections a little bit about the surgery, because I found it was a little bit confusing between the two. So I'll come and tell you in a bit, or show you in a bit, how to mention them each. Okay, very simply. You talked about why did it happen again, because that was one of the patient's questions. So you talked about weight, chronic cough, and family history of prolapse. So it can be like inherited weakness in the pelvic muscles. So no matter what treatment she has, she would be at risk. But it's most important to work on the risks that she has. And for the family history, continuing with the pelvic floor exercises even after surgery would prevent it from recurring again, or at least decrease the chance of it happening again. And you explained that very nicely to her. The patient asked, will it happen again? You addressed it really well, and you related it to the family history of the prolapse, okay? And you can also add that even if a low-risk woman has surgery for a prolapse, there's still a small chance after each surgery for the prolapse to recur again. So that's something normal that can happen. But in her case, her chances of it recurring again would be a little bit higher, right? And you also talked about how to reduce the chance of it happening again. So well done. You gave a leaflet, you wrote back to GP, and you involved the consultant. But then you forgot two things. They're just like in urogynecology when we did the video on incontinence, stress, and overactive bladder. Before any surgical option, local MDT, and then would be the patient has to know that her personal data, in terms of her number, address, NHS number, and her clinical medical details would be registered into the National Registry. Okay, and a copy would be given to her about the details later on, and she would have follow-up for at least 6 months after any of the surgical options. Okay, so don't forget to add these two, because if there's communication with colleagues upon the domains, the MDT would be part of it, local MDT. And if you forget mention local MDT, you can fail a whole domain very easily. So pay attention to that. But if there wasn't any communication with colleague domain in that scenario, then forgetting the local MDT wouldn't really change or affect your marking very much. So let's come to the operations. Now I'll take the heart away. We do know that there's two types of operation. I've written the names here because, believe me, honestly, I can't memorize them. It's sacrospinous fixation with sutures. That's number one. And then there's sacrocolpopexy with mesh. So the sacrospinous fixation with the sutures, we know that it's done vaginally, and they use sutures. They don't use any mesh. And you can tell her that the surgical operations that we have are basically to lift the vagina back into its place, or to lift the upper part of the vagina back to its place. You can either have it done vaginally, in which stitches would be done to lift the upper part of your vagina and attach it to the top, attach it to a ligament in the pelvis. Since there would be no scar in your tummy, only in your vagina, you can stay around 1 to 2 days in the hospital. You would have either general anesthesia to be put to sleep, or you can have it under spinal anesthesia, in which you would be numbed from your nipple line downwards. There are risks associated with it. You can expect to leak when you for exercise for a while, what we call stress incontinence. You can have problem emptying your bladder fully and may need to have a catheter inserted for a while as well. And you can have pain on your buttock just because of that suture being there on the lower back. Do you have any questions? The other operation that you can have is through your tummy, and basically be doing the same thing, just attaching the top of your vagina, but this time it would be to a bone on the back of your spine. And it can either be done through keyhole surgery, in which we would just insert a camera through your belly button, have 2 small cuts on the side, or it can be an open surgery, just a cut above your bikini line. If you do want a keyhole surgery, it would depend upon if there's an expert doctor available. If not, then, and you still want it, we may need to refer you to another hospital. All right, she'll tell you yes. And then you talk to her about, sorry, I forgot the success. The vaginal one, you tell her success around 70 and 100 women get relieved from their symptoms. And for the tummy one or the abdominal one, 85 out of 100. So that second one is more effective than the first one. But if you do have it open through a cut on your tummy, you may need to stay around 2 to 3 days. With through keyhole surgery, around 1 to 2 days. Although it's more successful than the previous one through your vagina, this one has complications associated with mesh, because we will not be using sutures. We'll be using a mesh. A mesh is a foreign material. It looks like a net that would be staying permanently on your body. Sometimes this piece of net can rub into organs nearby, and that can cause ulceration and sore areas. It can cause really long-term pelvic pain or pain in your lower tummy that can be difficult to treat sometimes. In addition to that, you may have problems opening your bladder or emptying your bladder, and you may need to have a catheter inserted, and you may feel constipated for a while. So this is how you compare each, okay? And most importantly, when you talk about mesh, mention the risk of mesh erosion. Ask her at the end, so what are your thoughts at the moment? So you can show the examiner there's this shared decision making between you and the patient. It's not just you giving her the management options. So here are the options now. Here's a leaflet, go home and come back later. No, check what she wants. Sometimes she can tell you, okay, I want this option. Tell her, all right, I'll give you a leaflet to read more about it. I'll be arranging the meeting to review a case, and then we will come and consent to you later on after the decision is out. She'll tell you yes. Okay, so we'll be arranging a further appointment. Sometimes a patient can tell you, well, I can't really make up my mind at the moment. Tell her, okay, that's not a problem at all. You can take your time. I'll give you a leaflet. It has everything that we talked about in much more detail. And when you make up your mind, you can come in at any time. And if you do have any questions meanwhile, just on the back of the leaflet, you can just write them down so we can discuss them next time. All right? So during this time, what we advise you to do to work on the exercises, get your asthma controlled with your physician, and try to drop a bit of weight. She'll tell you okay. So you gave a summary of the plan of management. So always have a few seconds at the end to have a summary. Okay. So yeah, that's it about pelvic organ prolapse, especially vault prolapse in a postmenopausal woman. Thank you. Bye-bye.